Hit me! You are listening to Physio Shorts, where I share helpful articles so you waste less time and get more value. Hosted by yours truly, Dustin Jones. Hello friends, this week's Physio Short comes from the infamous Kyle Ridgeway from ptthinktank.com. This is an article titled Metacognition, Critical Thinking, and Science-Based Practice, #DPT Student, written on January 6, 2014. Metacognition can be considered a synonym for reflection in applied learning theory. However, metacognition is a very complex phenomenon. It refers to the cognitive control and monitoring of all sorts of cognitive processes like perception, action, memory, reasoning, or emoting. A recent #DPT student tweet chat dealt with the concept of metacognition broadly, but more specifically discussed the need for critical thinking in education and clinical practice. Most agreed on the dire need for critical thinking skills, but many #DPT students felt they had no conceptual construct on how to develop, assess, and continually evolve thinking skills in a formal, structured manner. Many tweeted they had never been exposed to the concept of metacognition nor the specifics of critical thinking, although most stated that critical thinking and clinical decision-making were commonly referenced. What's more important than improving mental skill sets? Thinking is the foundation of conscious analysis, yet even with a keen focus on assessing and improving our thinking capacities, unconscious processes influence not only how and why we think, but what decisions we make, both in and out of the clinic. We are humans with biased minds, brains that, by default, rationalize, not thinking rationally. Everyone thinks. It is our nature to do so, but much of our thinking, left to itself, is biased, distorted, partial, uninformed, or downright prejudiced. Yet the quality of our life and that of what we produce, make, or build depends precisely on the quality of our thought. Shoddy thinking is costly, both in money and in quality of life. Excellence in thought, however, must be systematically cultivated, and that was via criticalthinking.org. We need a model. Mary Derrick observed previously in her post that the words critical thinking and clinical decision-making are often referenced without much deeper discussion as to what these two concepts entail or how to develop them. Students agree that critical thinking and sound clinical decision-making are stressed in their pre-professional education, but all levels of education appear to grossly lack formalized courses and structured approaches. The words are presented, but rarely systematically defined. The actual skills rarely practiced and subsequently refined. Students thus lack not only exposure and didactic knowledge of metacognition, critical thinking, and decision-making, but also lack experience evolving these mental skills. We need to teach how to think. Alan Besselink argued a scientific inquiry model to patient care is, from his view, the one approach. In quotations, there is in fact one approach that provides a foundation for all treatment approaches: sound, science-based clinical reasoning, and principles of assessment combined with some sound logic and critical thinking, end quote. Another quote, one approach to all patients requires an ability to gather relevant information given the context of the patient scenario. This occurs via the clinician's ability to ask the appropriate questions, utilizing appropriate communication strategies. Sound critical thinking requires the clinician to hold their own reasoning processes to scrutiny in an attempt to minimize confirmation bias, if at all possible. It also requires the clinician to have a firm regard for the nature of normal and the statistical variations that occur while adapting to the demands of life on planet Earth, end quote. Philosophically, I agree. It appears the question, what works, has been overemphasized at the potential sacrifice of questions such as how does this work? Why do we do this? And why do we think this? Unfortunately, the construct of evidence-based practice assumes the user applying the evidence-based practice model is well-versed in not only research appraisal, but critical thinking. The structure of evidence-based practice overly relies on outcome studies. It lacks a built-in process for integration of other sources of knowledge, as well as the applicable question of does this work as theoretical proposed. The evidence hierarchy is structured and concerned with efficacy and effectiveness only. Many will be quick to point out that from a scientific rigor standpoint, the evidence hierarchy is structured as such because other forms of inquiry, basic physiology, animal models, case reports, case series, etc., cannot truly answer questions what works without significant bias. Robust conclusions on causation cannot be made via less controlled experiments, and this, of course, is true. In terms of assessing effectiveness and efficacy in isolation, the evidence hierarchy is appropriately structured. But the evidence hierarchy does not consider knowledge from other fields nor basic science, and thus by structure explicitly ignores plausibility in both theory and practice. To be fair, plausibility does not necessarily support efficacy nor effectiveness, so it is still imperative and absolutely necessary to learn the methodology of clinical science. Understanding how the design of investigation affects the questions they can truly answer precedes appropriate assessment and conclusion. Limits to the conclusions that can be drawn are thus explicitly addressed. Need the why. Because of the focus on evidence-based practice, which inherently values randomized controlled trials and outcome studies over basic science knowledge and prior plausibility, students continue to learn interventions and techniques while routinely asking what works questions of how did I decide what works, why do I think this works, and what else could explain this effect, also need to be commonly addressed in the classroom, clinic, and research. Such questions require formalized critical thought processes and skills. These questions are especially applicable to the profession of physical therapy, as many of the interventions have questionable or at least variable theoretical mechanistic basis in conjunction with broad-ranging explanatory models. This is true regardless of effectiveness or efficacy. In fact, it is a separate issue. Physical therapy practice is prone to the observation of effect followed by a theoretical construct that attempts to explain the effect. A focus on outcomes-based research perpetuates these theoretical constructs even if the plausibility of the explanatory model is unlikely. In short, while our interventions may work, on the whole, we are not quite sure why. Jason Silvernail's post, EBP, Deep Models, and Scientific Reasoning is a must-read on this topic. The profession suffers from confirmation bias in regards to the constructs guiding the understanding of intervention effects. In addition, most, if not all, interventions physical therapists utilize will have a variety of non-specific effects. These two issues alone highlight the need for critical thought in order to ensure that our theoretical models, guiding constructs, and clinical processes evolve appropriately, and, further, to facilitate appropriate interpretation of outcome studies. It is not what works versus why does this work. Instead, a focus on integrating outcome studies into the knowledge and research of why and how certain interventions may yield results is needed. This requires broadening our evidence lens to include physiology, neuroscience, and psychology as foundational constructs in education and clinical care. Further research agendas focused on mechanistic-based investigations are important to evolving our explanatory model. Education, research, and ultimately clinical care require both approaches. Interpretation, integration, and application of research findings, be they outcomes or mechanistic, necessitates robust cognitive skills. But do we formally teach these concepts? Do we formally practice the mental skills? So now what? There appears to be an obvious need and obvious value to learning how to think, but that is just a start. The necessity of learning to think about thinking is required to improve the specific skill of critical thinking. The understanding and application of evidence-based practice needs more robust analysis. Growth of critical thinking, metacognition, and an evolution of evidence-based to science-based practice produces the foundation for strong clinical decision-making. The call for evidence-based medicine to evolve to science-based medicine focuses on ensuring clinicians interpret outcome studies more completely. It appears to put strong emphasis on increased critical thinking and knowledge integration. And this is a link to Does Evidence-Based Medicine Undervalue Basic Science and Overvalue Randomized Controlled Trials? A difference between Sackett's definition, evidence-based practice, and ours, science-based medicine, is that by current best evidence, Sackett means the results of RCTs. A related issue is the definition of science. In common, use the word has at least three distinct meanings. The scientific pursuit, including the collective institutions and individuals who do science, the scientific method, and the body of knowledge that has emerged from that pursuit and method. I will argue that when EBM practitioners use the word science, they are overwhelmingly referring to a small subset of the second definition. RCT is conceived and interpreted by frequentist statistics. We at SBM use science to mean both definitions 2 and 3, as the phrase cumulative scientific knowledge from all relevant disciplines should make clear. That is the important distinction between science-based medicine and evidence-based medicine. Settled science refutes many highly implausible medical claims. That's why they can be judged highly implausible. Evidence-based medicine, as we've shown, and we'll show again here, mostly fails to acknowledge this fact. What do we do? Learn how humans think by default, biased. Learn the common tricks and shortcuts our minds make and take. Understand logical fallacies, cognitive biases, and the mechanics of disagreement. Metacognate. Think about your own thinking with new knowledge. Find a mentor or partner to critique your thought processes, prove yourself wrong. Critique thought processes, lines of reasoning, and arguments formally and informally. Debate and discuss using a formalized structure. Think, reflect, question, and assess. Discuss and disagree. Repeat. Science-based practice. Number 1, foundations in basic science, chemistry, physics, physiology, mathematics. Number 2, prior plausibility. Grand claims require grand evidence. Number 3, research from other relevant disciplines, from physics to psychology. Number 4, mechanics of science, research, design, and statistics. Number 5, evidence-based outcomes hierarchy. Questions lead naturally to more questions. Inquiry breeds more inquiry. Disagreement forms a foundation of debate, and thus Eric Robertson advocates for embracing ignorance. Ignorance is not an endpoint. It's not a static state. Ignorance isn't permanent. Instead, it's a tool that enables one to learn. Ignorance is a spark that ignites scholarly inquiry. Ignorance, the secret weapon of the expert. Growth is rarely comfortable, but it's necessary, and that's a lot to think about. Thanks, Kyle. Hit me! Thank you for listening to Physio Shorts. If you found this helpful, head on over to seniorrehabproject.com, where you can find more Physio Shorts episodes, as well as look at the other podcasts on the Senior Rehab Project Network. I appreciate you, and until next time, my friends, do not forget to stay funky.